Oh, hey, Chris.
Hey Chuck, how are you?
I am really good. How are you?
I'm great. It's we're at the end of March now. And we're going to be, heading into April pretty soon. Spring is coming. The weather in St. Louis certainly reflects that.
My God, it is. I do suffer from seasonal affective disorder, although I should say that carefully. I don't really suffer, and I'm sure there are people who do, but I need sunny weather soon.
Yeah, absolutely. Well, we've decided, so I didn't realize this was a thing until we moved to St. Louis. The pool opening and closing thing didn't happen in Florida. The pool was always open in Florida, no matter whether it was cold or hot. But we decided to open the pool on May 1st, and I'm really super excited about that. So it's kind of like a countdown to that. That's at least what's going on in our house.
Yeah, the other reason I'm excited is I heard once that someone didn't think our audio in our podcast was top notch, and I think it's pretty good. And no one's ever complained about it except for one person said that. But we have seriously upped the game, and I have to share with you. But I'm using a new mic. I got these sweet new headphones, so I'm feeling pretty professional right now.
Well, being a boss will step it up like that. I think that and you're the kind of person that, you'll take that one bad patient review and change things to make it better. So,
Well,
one thing that was kind of interesting this week, I had my first clinic yesterday without wearing a mask. Totally weird.
yeah, and we have a guest here. Maybe we should just loop her in because she's feeling the same way. So our favorite and most recurring guest is back.
By
Macy,
popular demand, I should say.
by popular demand. I think, in fact, they may want to vote one of us out off the island and just keep Macy here as a host. Macy
Welcome,
Stoner's
Macy.
back.
Hi, everybody. I'm glad to be back.
How
And
did
I
you
agree
feel?
about the masks. I had my first clinic. Sorry, I can hear my dogs barking.
Yeah, so our institution just went to a mask or was it what's the word? Situational masking
Situational masking at the request of the patient, basically.
at
Well,
the
I was
request of the
in,
patient based on obviously different clinical scenarios you should be wearing one. But I think I wore a mask for one patient, and it's because I felt weird not wearing one because they were wearing one and they said it was fine. I just put one on anyway. But yeah, how was it for you, Macy?
so at first I was a little weary about it and decided to keep wearing one. And then I was in Dr. Goldfarb's clinic on Thursday and I noticed that he wasn't wearing one. And I thought, oh, I'll just give it a shot. I loved it. I really felt like this deeper connection I was able to make with patients, just being able to play off each other's reactions. And I don't know, I just felt more connected to each patient and I loved it. So I think I'm gonna keep going.
I've been traveling a little bit, even after Vegas, where Chris and I recorded a couple of pods. I traveled last weekend. I still wore a mask in the airport and on the plane, but man, it is very few people with masks on traveling.
I will say this partially joking, but I will use situational masking perhaps when I'm on the plane and I don't want anybody to see my mouth open and I'm sleeping.
There's truth
um,
there. There's truth.
and I'm realizing a couple of things about yesterday's clinic that first off, like I have known some of these people for like 3 years and have never seen their face. I mean, it's amazing, and they've never seen my face. Like, so it was quite odd to like see people's faces, and especially people that in whom we've operated upon. And that's for lack of a better word, a pretty intimate relationship to be operating on somebody and never seen their face. So that was interesting, and I think that was a nice connection. It felt really good. But then I realized halfway through my clinic that I could not show all of my expressions like I would if I had a mask on. Like a
That's so
patient, like the
true.
the, the downside of what you're talking about, Maisie, like hearing a patient say something, I couldn't purse my lips. I couldn't be like, "Oh my God," because I'm used to keeping it okay from like eyes up or nose up. But so yeah, I have to mind myself. It's kind of like getting on the back on a bike, right?
Yeah, it's Macy's probably experienced this. Little kids are interesting because you really connect with them with a big smile and but I think they also can read eyes just like we can read eyes. We can see smiling eyes, and I think all of us are going to be a little more perceptive about subtleties and facial expressions. Um, but I'm also a little worried about getting sick. Like I haven't
Mhm.
had a common cold in 3 years, and I know they're going to start coming back, and that's one huge benefit that was really nice.
Well, Macy knows that life as well in terms of the daycare slash elementary school germs that both of us have been fending off for the last I guess since the school year started. So that we're ahead of the curve there for you, Chuck. Hopefully we won't spread anything to you.
So we have a topic which on the surface may not sound like the most exciting topic, but
It's
we've
definitely
had
not the most exciting topic. I'll tell you that right now.
but it's filled with controversy, and people really feel strongly. So we're going to talk about mallet fingers,
But
which
you do have to talk about it. Like that's the thing, is that like it's a conversation, and this conversation that comes up frequently.
yeah, there's no therapist or hand surgeon out there who doesn't deal with this problem regularly.
Well, before we get into it, we should thank our sponsors.
You are so good. We definitely should thank our sponsors. The Upper
The Upper
Hand.
Hand, we're just going to do it in unison. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job does not have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand. And, I've enjoyed our conversations with PracticeLink. I think you and I owe the founder a coffee and a discussion one morning, but it's a good group.
Right, absolutely. What's funny is I was talking with somebody about the podcast and the sponsorship thing, and they asked like, "Hey, do you guys just like record that and just like insert it every time?" And I think how we just flubbed that copy totally shows that we do not just insert it every time.
No, from the heart. All right, well, let's how should we start this?
Well, here, let's do a case, right? So,
Perfect.
say you've got a young investigator eligible under 40 type dad who is playing ball.
Are you still under 40?
It's the only way I got the award, buddy. So no, it's funny because I've been walking through the hospital, and like apparently it's been like people have been told in the South County OR, one of our satellite centers. So people are like, "You're still under 40?" Like, yes. I'm holding on for a few more months. But say it's a young dad who is playing ball with their child, and his daughter throws the ball quite hard, and he tries to catch the ball, and it's been a while since he's played ball, and there's a sudden hyperflexion moment to his middle finger, and he comes in and he can't straighten out his finger. Happened, I don't know, a month, or it happened, let's say a week ago. He went to an urgent care center, got x-rays were negative, and they put him in an alumifoam splint from the palm extending past the tip of the finger. It's all co-band up. He hasn't moved his finger in a week. So Macy, how do you, because sometimes, when we're collaborating with you in clinic, sometimes you'll see patients before us. So how do you approach that discussion, and kind of what are the other history points you want to take?
Can I, before you answer, can I say one thing? So
Yeah.
for those in the outside world who don't have the benefit of working with Macy or someone like Macy, it's like the best possible situation, because often we'll have a resident or fellow who goes in and they may or may not understand all the issues, and they may or may not get it right. Macy always gets it right. Like, she's been doing this a long time, and when she comes out and says something, I just
not that long, Chuck. Not that long. Okay.
She's under 42, I think. You're also in a special state. Can we talk about that for a second? How do you feel?
I feel good. For those who are listening, I'm 3 weeks out from having a child, and
you might not hear from Macy in a while, guys.
Yeah, I'm glad we snuck.
I feel good. I feel like this pregnancy is a little harder because I have a toddler to run around and chase after, but overall feeling good, feeling ready, feeling grateful for all the things that come with it.
Yeah, well, I'm glad we snuck this pod in. I don't know why. I felt like I hadn't seen you in a while, and maybe we missed a clinic or something, but you were in clinic with me on Thursday, and I was like, oh my God.
Yeah, you definitely saw me and your eyes got big and you're like, whoa, you look different.
Well, I mean, we should do a public congratulations to Macy. This is as close as we'll get to a baby shower on the Upper Hand.
Thank you. Do you want me to continue to talk about Mallet, or do you want me to keep talking about other things?
Well, I think Chuck was talking about how awesome it is to have you in clinic, so probably should finish that thought, and then we should get back to Mallet.
All right. Yeah. Well, y'all are very sweet. Thank you. But regarding that patient, I feel like one of the first things I want to address is like, hey, isn't to not say, oh, you've been doing this wrong. You need to be moving these joints and your splint's wrong, and you're mismanaged in some way. Just say, nice job. You've been splitting for a week full time. But, we really want to customize that splint a little bit more, give you more freedom at some of the more proximal joints, and support your tip of the finger a little bit better. So we're probably going to send you over to therapy today to have a different brace made and kind of go through some specific education and instructions on what to do for the next 6 weeks or so, and kind of educate them a lot on the anatomy, because a lot of times
that is like totally Birmingham nice, the way that you just did. Like so much grace to be like, well, good job on the splinting for a week. But I love that. I'm sorry to interrupt you, but how would you educate them on the anatomy?
Sure. So I'm just going to give my spiel a little bit. I'll take out our anatomy book and I'll show them like the extensor tendons on my hand and describe it like you have a rubber band on the back of your finger that got jammed or overstretched. And if you have a hair tie or rubber band that gets stretched out, it's hard to get back to that tight tension that it once was. And so then I kind of show them my finger and explain, okay, we got to keep this really straight for 6 weeks or so. Through dedicated splinting, because as it heals in that straight position, think about a lot of scar tissue that gets built up on the back of your finger and it tightens up in a good way. And then after 6 weeks, you take the splint off and hopefully it magically stays straight like that. And I explain it like it's splinting with a commitment, because if you take it off for showers or for intermittent activities, you have likely let your finger droop and we want to keep it tight for 6 weeks. So it's definitely a commitment, and we'll kind of go through some strategies of how to take it on and off to clean your hand and monitor for maceration without letting your finger droop. That's kind of like a little bit of my spiel.
No, your spiel is great. We have a lot of different angles or leads we need to pursue.
Sure.
So number one, Chris, does every patient deserve an x-ray?
No, but I think that no, in terms of decision making and what to do. Yes, in terms of, dare I say, therapeutic or XRT, in terms of showing them, like a lot of times patients will think like they didn't even do an x-ray. And that honestly contributes to kind of patient satisfaction. So I think getting an x-ray, especially one that can be done quickly and with very low radiation in terms of the fluoroscan, is beneficial in terms of the relationship, but I don't need it to make the diagnosis and to guide management pretty much every time, unless I have a high suspicion for a bony mallet. So that I think is how I think about it. How do you think about it?
I think every one of these patients should have an x-ray, and part of it is for the reason you said, and part of it is occasionally I'll be surprised there'll be a larger than expected fragment. There might be joint subluxation, and I had this conversation with Jess on Thursday that sometimes you come to the orthopedic surgeon at a big referral center and you just got to get the x-ray even if you don't really need it. Like CMC arthritis is another example. From across the room whether they have CMC arthritis, and sometimes you just got to get the x-ray.
Yeah, I think there certainly is an expectation. Going off topic for the CMC thing, I think we talked about this before. I usually will get the x-ray for getting the surgical planning. But I tell the patient specifically why I'm not getting an x-ray, and that's part of the initial counseling spiel for that particular condition. Macy, I love the rubber band analogy. I have not heard that, and I will probably start using it, in terms of how I counsel patients. So I love that, especially the tension part of it and everything.
Mm-hmm.
Can't hear you, Chuck. You'd think after 3 years we would have figured out the Zoom thing. Huh?
You're muted.
You're not supposed to say you're on mute. I thought that was a thing. Like you're not supposed to say that. I'm just kidding.
Did one of you mute me?
Yeah, the host has been muted.
So Macy, I think Chris and I feel strongly that the splints that you custom make for patients are perfect, are really good and they make sense. I think some of our listeners probably don't send their patients to a therapist for a custom splint, and they get by with a Lumafoam.
Or a stack splint.
Or a stack splint, exactly. Can you, and I'm asking you to sell your services a little bit, can you explain why you think a custom splint matters? And can you describe the splint or splints that you may design for a patient?
Absolutely. So in clinic Thursday, in your clinic, there was a little boy that had a mallet injury. He had a Lumafoam splint to the palm, just like you described. And when I went in there, I evaluated the positioning of his finger in that splint. His PIP was in hyperextension and his DIP was in a little bit of flexion. And I think that it requires a hand surgeon / therapist's eyes to monitor that and to ensure from a, lateral view, looking in the splint, that everything is positioned perfectly. And, you can get by with a prefab wrist splint or other things, but the details of a finger can be so different for everybody. And I think that being able to customize something is important. So for example, I will ensure that the PIP joint is exposed and free. That's difficult to do with the prefabricated splint, because I don't want them to start swan necking or get stiff there. And a lot of times they're really swollen, and we have them come back at 7 to 10 days and have it remolded to accommodate for those changes in swelling, because oftentimes you put them in the splint and they have them in a little bit of DIP hyperextension, have them come back, their swelling's down, they've kind of shifted in their splint a little bit, and then they're in a little bit of flexion on accident, and they go the next 5 weeks in flexion. Or, kind of takes quite a bit of understanding. Health literacy might be a good term for this diagnosis to be successful, because sometimes people will come back and their splint's on upside down a lot of times, and they're being positioned in flexion. So I guess I'm getting at, the importance of a follow-up to ensure everything's going okay. But the splint, going back to that, is something that can be volar to push them up into a little bit of hyperextension, not too high on the sides, because sometimes that allows the finger to droop down. You have to be very careful with your strapping system to make sure that they're supported well. This is all kind of hand therapist lingo. And then we always make 2 at our clinic, at least one on the volar side and one on the dorsal side, to distribute pressure over 6 weeks and prevent, skin breakdown and too much pressure on one side, so they have options to go from one to the other. But it's definitely one that I feel strongly that you can't really get a prefabricated off the shelf one to support you well.
I love that. And, I think the multiple splints is key. I think it's probably the biggest advantage among all of the ones that you described. I didn't realize that you had patients come back for a follow-up visit. I kind of thought it was a one-time deal. So I'm
It
learning
can
too.
be for some patients, like you kind of feel out the patient. And, I had this physician the other day who just needed a splint, and I was like, no, normally we come back in 7 to 10 days. And he was like, no, I'm good. Like, I get it, but typically that visit is really important, because you just make sure that they are well equipped with all their splinting needs. You give them a little bag of Velcro and different types of devices, Coban or whatnot, to ensure that they are set with all their stuff for 6 weeks, to accommodate for changes in swelling. Or I make a volar one and a dorsal one, and 9 times out of 10, they hate the volar one and they just want the dorsal one. So I end up making a second dorsal one for them. And so just kind of making sure that they understand the program. I document that I can, I watch them transition from one splint to the other without breaking precautions or without letting the finger droop, because some people just don't get it. They'll put on one splint, like they're in the shower, like to mimic that they just came out of the shower and it's all wet. And then I'll have them show me they can put the other one on, and then they let their finger rest unsupported, and then they droop. So it's a lot of reinforced education. Sometimes the people just really aren't getting it, those people that come back, 3 or 4 times, but typically it's 2 visits.
All right. I love it. I have 1 comment and 2 questions. My comment, and Chris and Macy, I'm curious as to your thoughts. I see a lot of athletes, and this is one that's hard for me, because I don't know of many sports that you can play during the healing process with a mallet splint on. So I'm trying to think of an exception, but this is one of the ones that frustrates me, and I know it frustrates families and patients and athletes. I generally don't let people play with a mallet injury, because I don't think we can keep the splint on effectively. We can try and we can tape it on, but it comes with risks. Is that a fair statement, or do you guys disagree?
Dr. G, do you want me to go first, or do you want to go first?
You should go first, Mace.
Okay. I think I agree for the most part. I think there's a few cases that could probably be okay, depending on the sport, I guess, and how protected the finger is. But if it's a small finger and there's not a lot of real estate there, and those are really tough to splint, and I feel like the splint comes off a little bit more frequently. If it's a long finger and it's, I guess, like I'm thinking of a guy that has a really long hand and it's pretty solid on there, and I Coban it really well to his finger, and he's comfortable and solid, I think there's probably a case where like that would be okay. But I think it would require the right person who gets it, I guess.
Yeah, I kind of just tell them you can do whatever you want in the splint, just to make sure the splint stays on, and it's your risk. And I don't see I'm not as fancy as you in terms of seeing the elite athletes, or just many athletes. I mean, I see some kind of a high school kind of amateur kind of thing, but I guess the next, I'd love your thoughts on that, Chuck, but then also I'd love to ask you, like, what if it was a surgeon and they needed to scrub? Are you just going ahead and pinning the joint? And do you think that's reliable? Would you ever do that in an athlete? But because if the pin breaks, that's a problem.
Yeah, I think it's a good point. And in general, I just tell them if it's an elite high school athlete or a college or professional athlete, I think they're just down unless they get it pinned. And I do think pinning is reasonable. And sometimes you go with a larger pin because I don't think the forces across that DIP joint are all that great. And I would try to have them wear a splint. But even the weekend warrior who just can't imagine wearing that splint, I have pinned. And it's a fine line. I do bury the pin. I leave it in for 6 weeks. I try to insert it under local only anesthetic, and I try to leave it proud enough that I can take it out in the office. But it's a great solution, but it does have problems. Macy?
Did that patient ever get stiff with DIP flexion? Was that ever an issue regaining movement?
It's not.
No.
I've not seen that issue.
Yeah, I haven't either with the conservative route, so I was just wondering.
My 2 questions, not to belabor this too much. Number 1, when do you include the PIP in one of your splints? And I say it carefully because I think usually when we have a splint that includes the PIP joint, we also have one that does not. And the second, and our colleagues from across the seas who are listening are probably curious, cost. And our system doesn't manage cost well, and it's not inexpensive to send a patient to see you, Macy.
Unfortunately, you were right, and I wish that I had a say in that. So cost, I don't even know if I'm allowed to say this on the air, but I'm going to. At our clinic, we do not charge for mallet splints. They're not free, but when we submit our charges, we submit how many minutes or like the time it took to take it. So it's like called initial orthotic management. So it's not an L code, meaning you don't get charged hundreds and hundreds of dollars. So that's something that's changed over the years when we've kind of modified our fee schedule. I can't speak for every clinic on that.
I think there are some, well, I mean, just before you go on, there are some health systems where this injury is initially evaluated and completely managed by hand therapists. And I think that happens in the UK.
And then the other question was, PIP. So there's 2 cases in my mind that I'm thinking why I include a PIP. Number 1 is if they are a little bit further out from their injury, or they've got a lot of laxity and they're swan necking quite a bit. So I will make a splint for nighttime or as needed during the day that keeps their PIP joint in a little bit of flexion and the DIP joint in hyperextension. So that's one reason why I'll make a PIP included splint. The other one is if it's a pinky. Like I mentioned earlier, there's not a lot of real estate. And so if you have a DIP only splint, a lot of times the patient doesn't feel secure or they feel like it's going to fall off. So I'll make an additional one that goes to the entire length of the pinky with the caveat that, hey, don't wear this all the time. I don't want your PIP joint to get stiff, but at night when you feel like it's going to fall off or you're going to be doing a heavy activity, feel free to wear this big one because you feel more comfortable in it. And then I put them in that and they're like, oh, this feels so much more supportive. And then they kind of alternate back and forth between the 2.
I think that's well said. And just to be clear for maybe some less experienced listeners, part of the goal of a good DIP joint immobilizing splint is maintaining the PIP joint. Because I say this to patients all the time, I don't really care about motion at the DIP joint. I'd like you to regain full motion, but I really care about motion at the PIP joint. And so the beauty of this system is that you can keep your PIP moving and not worry too much about the DIP. What, Chris, how do you think about, so let's say 6 weeks comes up or 8 weeks comes up and the patient comes back and you say, okay, now it's time to get rid of the splint. What do you tell them? And I'm curious what you tell them, what Macy might tell them, and whether we are the same.
Sure. I mean, so, I guess from the beginning, the initial conversation, I tell them we're going to splint this for 6 weeks. And I guess we could ask, like, why 6 weeks? Why 8 weeks? I think it's total orthopedic, dogma. 6 weeks should be enough, right? And I tell them at the beginning that everybody ends up with a droop. And we're going to do this for 6 weeks and let scar tissue build up. But I remember every time in Ryan Calfee's clinic, just him kind of showing them, everybody ends up with, just kind of comes down here. You start up here after you come out of your splint, and you'll end up just with about maybe a 15 to 30 degree extension lag. And he calls it a droop, and people get that. So, and I think that that's something that you got to tell people from the jump. So, when we have the initial conversation, I tell them that when they come back to the office, I love asking them, "Hey, how's it going? How's the splint been? Show me your finger." And I know who's been wearing their splint properly and who has not been wearing their splint properly, because the guy who just goes, "Oh, there you go," and just rips it off, clearly has not been properly wearing their splint. Then there are the patients who are wonderful, who appropriately, like on the little hand table that we have, will take out their hand and put it on the edge and appropriately take off their splint. And then when you ask them to move it, they're like, "Really? You want me to move it?" That's the right patient. And you could totally tell where this is going to go. And I put that in my note that, when, patient took off the splint, took off the splint, didn't seem to follow precautions or whatever. But then I'll tell them, at this point, I have them wear the splint for another 2 weeks at night. And I don't know why. That was one of the faculty, I think it was Ryan, does that too. And he may not still do it, but he did it when I was in training. And then I tell them kind of get back to using things, wear it at night or when you're doing heavy activities for 2 weeks. If you feel comfortable more comfortable keeping it on when you're playing sports or whatever, go ahead and do that too. You'll probably end up with a little bit of a droop. Usually most people don't have a problem with that, but if you do, let me know. How about you, Chuck? What's your spiel?
Well, my spiel's the same. I do like the concept of 2 weeks at night, 2 weeks with sports. I just think it feels better to the patient rather than, okay, it's 6 weeks, you're free. See you later. You've been wearing this splint religiously for 6 weeks, now you're free. The one other thing I tell them and make a big deal about this is no passive flexion of the DIP joint.
Oh, yeah. Absolutely.
And I just say, look, don't worry about getting your flexion back. You will get it back, I promise. Just use your hand. Don't push down on it. You'll get your motion back. And before we hear from Macy, the one other thing I think that's really important is your point about initial conversation and expectation of a droop is super important, because there will be patients that are unhappy. And it doesn't matter what you tell them, but at least if you tell them when you start, you've told them. And if you don't tell them when they start that they may have a little droop, it increases the risk of frustration, even if it's irrational frustration. Macy, how did Chris and I do with our therapy recommendations and care recommendations post 6 weeks of splinting?
Totally agree. I typically say between 2 and 4 weeks, depending on your desire and like how tight they look. Like if they show me their finger and they look rock solid in extension, yeah, I think 2 is great. If they're a little bit more flexible and they kind of droop a little bit, I might say, this is up to you. If you're satisfied with this, you can live your life like this. It's fine. But depends on what your desires are. And I think 2 to 4 weeks is great. Still wear it during heavier activities, or if you're nervous during something. I totally agree. I have them maybe make a few slow fists, open and close, just to kind of help loosen things up. But again, no forceful gripping, no passive flexion, that kind of thing.
I love it. And I love the fact that this conversation has been primarily about non-surgical care. We should touch on surgery. It's a huge minority of patients that end up going to the OR. Chris, I'll put you on the spot. What are your surgical indications for soft tissue or bony mallet?
I very rarely have a surgical indication. I don't think I've ever operated for a soft tissue mallet. We talk about the kind of the person who will not tolerate or cannot tolerate the splint for various reasons. So the surgeon, the athlete, so I guess that'd be a reason to pin. I've not primarily repaired the terminal tendon back to the base of the distal phalanx, based on how I was trained in a number of studies that have demonstrated, no substantial difference in any outcomes. I do tell patients from the initial counseling when we're dealing with the soft tissue mallet that there is no good surgical solution that's going to make this better than if we treat you in a splint. And I think that's important because they're coming in to see a hand surgeon. So like when they come in for that, that's their expectation. So the first thing, and you totally score points when you're like, it's great news, you don't need surgery. And you're like, yeah, that really gets the conversation off to the right, on the right tone. And then in terms of indications for bony mallets, I think that, there was a lot of talk in the literature and in classic teaching about the size of the fragment, but I think more papers have demonstrated recently, including some meta-analyses. I think Julie Samora did one, looking at, it's not so much the fragment size, it's really more subluxation of the DIP joint. So that volar subluxation of P3 or the distal phalanx relative to the middle phalanx. How about you?
Yeah, I like what you said. I don't recall the last time I repaired the terminal tendon back to the distal phalanx. I don't, that's not really indicated in my hands very often, if ever. I will occasionally pin the joint for the reasons you stated. So then it gets down to really bony mallets and what are the surgical indications. And I don't think there's anything less clear in my world than that question. Dr. Lindley Wall, who's our partner, sees a ton of adolescents, and that population may be a little different, maybe a little more forgiving, and she really almost never operates. Even some mild subluxations, I believe she'll skip the surgery. For me, the absolute indication is a subluxated joint. And I do get nervous based on the size of the fragment and the displacement, whether that's rational, irrational, based in the literature or not. If I have a fragment that's 50%, and I think most of our listeners will say 50%, I would definitely fix that. I still hem and haw a bit, especially when there's a gap at the joint. And when you treat that surgically, you feel pretty good about it, but I just don't know that it's in the size of the fragment, as you said. I'm just not sure that's a real surgical indication.
Well, so say you have a 50% fragment, but the joint is not subluxated volarly. You still go after it?
Depends on the age, depends on the family, depends on the it's just, there's a lot of factors. It's not an automatic yes or no would be my lousy answer.
So then when you treat this surgically, are you primarily just pinning across the joint, or are you going after that tempting, juicy fragment?
Yeah, and I'd love Macy's thoughts on a couple of things I'm about to say. Number one, yes, I'm hopefully going to reduce the fragment, pin across the joint. It's a bit of a pipe dream to put a longitudinal K-wire through the fragment. So usually you're just pinning the joint and sort of trying to get that fragment down. I will sometimes use a dorsal block pin to try to improve the positioning, but I hate leaving that dorsal pin in. Because my experience has been those are the most likely to get infected and most likely to drive the patients crazy. Sometimes I'll just manipulate the fragment with a pin, but I don't like to leave dorsal pins in. Chris, I don't know what your thoughts are on dorsal pins versus just the joint immobilizing pin. And Macy, I'd love to hear your thoughts on those dorsal pins.
My thoughts will be quick, so I'll go first. I love the little joystick to help get everything lined up, make sure the joint's perfect. So dorsal pin in the fragment, I don't think I've ever left a pin in. I know that there might be some are tempted to put a little screw in there. It's probably overkill. You'll blow apart the fragment. Don't do it. So Macy, your thoughts?
Sure. I think that I've only honestly treated a handful of these before. And I think my feedback is that they, anecdotally speaking, they probably at the end maintain a little bit more rock solid extension, but lose a little bit more flexion, I would imagine. But I think that any patient that has pins in are freaked out to move their finger, whether it's a P1 fracture or metacarpal fracture or whatever it might be. So then they're a lot more worried about moving the PIP. And sometimes I think that like just by default, it gets a little bit stiffer and they're just a little bit more freaked out. But overall, I really don't have a ton to say about this population because I treat the majority, 99%, I would say non-operatively. If that's a fair statement.
My last point for this conversation, and you both may have other points you want to close with. When a patient has a chronic untreated mallet that's resting in 45 degrees of flexion and they are unhappy, they often have accompanying hyperextension of the PIP joint. And my favorite treatment for that, and it's not even close, is to ignore the DIP joint as long as it's flexible, meaning as long as we can passively move the DIP joint. I love a central slip tenotomy. I think it rebalances the dorsal finger and it's simple, it's effective. It's one of my favorite surgeries. Of course, I don't see that many patients that need it, but it is one of my favorite surgeries.
And you do that under local, right? You were doing that under local far before the Wallant stuff started, right?
I was, and I will, and patients tolerate it really well. Yep.
Yeah, there's one surgery that Dr. Marty Boyer always talks about in our anatomy labs when we talk about the extensor mechanism session. He always mentions how you're the one that showed him the way instead of doing the oblique retinacular ligament reconstruction.
Yeah, yeah, that is crazy. And obviously it's not my surgery. It's been around for 50 years, but it is a good one. And yeah, for those who think about an ORL reconstruction, oh my God, don't do it. Macy, take us home.
Yeah, I think that those surgeries are fun to rehab as well. Because it's very satisfying, like you mentioned, and I think that it works out well. I've only treated a handful of those. I also think maybe from you and Dr. Calfee, maybe, but I don't think that there's any issues that I've seen with them. And yeah, that's pretty much it. Thank you so much for having me again.
Well, we're grateful you're here. I think we've taken a boring topic and made it super exciting, right?
Absolutely.
Sure.
Hey, Chuck, I do have one more question just to close loop just for the listeners. So you have your pin in the joint, across the joint. How long do you leave it in, and what's your post-op protocol after the pin?
So the pin, this is one of those 6 weeks. Again, why, I don't know, but 6 weeks is the number. I do the surgery. I have them go to therapy to get a custom splint post-surgery to cover the pin. I see them back in the clinic at 6 weeks. I do get a mini C-arm, but I don't really care what it looks like. I remove the pin, and it's exactly the same protocol. Active motion only, no passive motion of the DIP joint. Is that
Back
how
to sport right away, or?
Good question. Probably not. Probably 2 more weeks and then back to sport.
Okay. Yeah, I think for me, back to sport usually is when you can make a full fist. It's just a general goal for, a lot of the hand stuff.
Yeah, Macy's heard me say this. I think I have 3 criteria for return to sport in general. Number 1, full motion. So your point is well taken. Number 2, strength, which is good and symmetrical, hopefully to the opposite side, or at least pretty close. And 3 is no pain. Those are my 3 criteria for most things as far as return to sport.
Well, I cannot believe we just talked for 40 minutes about mallet fingers.
Let's do it again sometime.
No, definitely not. Thank you, Macy, for joining us. Always fun.
Thank you all
Macy.
very much. See you next time.
Thank you. All right, you guys, that was awesome.
Okay.
Sorry about the dogs in the beginning. Typically, you don't have to tweak that, but it's reality.